Thank you. Okay, I'm going to talk about preventing post-op refractive surprise. This is going to be quite a simple talk. This is my financial disclosure. It so happened that most of us here, Kuan, Jascha, we have published a book on IOL calculations. You're all welcome to get it if you want. It's a 1,000 over pages book. At the very least, you can use it to build muscle because it's quite heavy.
What was the chapter?
Okay, this is a very well referenced paper from Stratton-Irving. My girlfriend is already very old. It's of 16 years. See, look at the various sources of error. This is, of course, statistically speaking. But I found that when based on my years of being referred refractive surprise, that they are still relevant to refractive surprise. For example, post-operative anterior chamber depth, one of the most common causes is using the wrong formula or using the incorrect IOL constant. In fact, I find surprisingly a lot of refractive surprise that was referred have incorrect IOL constant. And it doesn't make things better because today a lot of us have migrated to the new formula such as Barrett, Evo and so on, but we are still stuck on the A constant, which is the SRKT. So when you use a new formula, you're not familiar, for example, with the lens factor, then you are likely to make an error there. You still want to think back on what is the A constant. That's why I like to use the word incorrect IOL constant. The second, of course, inappropriate formula is also related to the fact that you didn't ask the patient that refractive history of the patient, and then you assume that the patient has had no LASIK done. When the patient has LASIK done, of course, you're going to have problems. Post-operative refraction is not uncommon. I think that many people find that whether also manifests standard repeatability of refraction is actually 0.45, 0.646 diopters. But this is only part of the problem, because if you ask different refractionists, they will actually give you quite different outcome. And even for the same patient, what is his name? George Waring always say that the repeatability of daily refraction of the same patient by the same optometrist is about half a diopters every day. So there is kind of repeatability problem here as well. Non-partial refraction is because today there are many partial range of focus IOL, especially the extended, the so-called EDOF lens. And if you don't refract them using the maximum plus, you may find that you have some refractive surprise. Axial length, mistaken optical axial length. I will show you an example later on. And of course, a confounded keratometry, all right? That means you are using the wrong keratometry, as in the past we post LASIK. And of course, I will show you in a while what I mean by confounded keratometry. Of course, if you can use optical biometry, in the days before IOL Master 700, I find that more than half of the refractive surprise are from ultrasound. The problem with ultrasound is because usually the patient is not fixating, therefore you're not measuring the optical axis. You're not measuring to the fovea, you're measuring from the vertex of the cornea to some other place in retina. But with optical biometry, where the patient needs to fixate, you're more likely to measure the optical axial length. And in fact, if you have to, don't do applanation, do immersions. Alright, so let's start with good keratometry practice. Always perform keratometry before any procedure, especially if you're going to use eye drop, because this is going to make a lot of PE, punctate epithelial erosion, then you're going to not measure the true cornea. If the cornea is dry, the new thinking is don't wet the cornea with lubricants anymore, but ask the patient to blink a couple of times and then either quickly repeat, do the keratometry, or you may want the patient to blink even more. Wetting the cornea with lubricants is a simple but inaccurate solution. Now, contact lens is something you must exclude. All right, hard contact lens 4 weeks or more, RGB 2 weeks or more, rigid gas permeable, soft at least a week, sometime more. All right, you repeat when the mean corneal power is less than 40 or more than 40. If you are using Hyon Master 700, when the standard deviation is of the keratometry is more than 0.05 diopters, I'm a little bit careful because it can be dry eyes or it can be just that it's not repeatable enough. Alright, when astigmatic power is more than 3 diopters, of course you have to be careful. I'm not saying they are wrong, you may want to be repeat the procedure of keratometry to find out more. Alright, or the difference in corneal power is more than 1 diopter, or the difference in astigmatic power is more than 1 diopter. Of course, if the patient is not fixating very well, uncooperative, you may want to repeat again, so you can repeat yourself, or you can get a second biometry to repeat it, or you can ask the patient to come back another day. Beware of contact lens. This is a published one. I have my own, but we just show one example. The first biometry was done, the K was quite flat. Okay, and fortunately the biometrists know what exactly happened. You ask the patient, and the patient just stopped contact lens 1 day earlier. If you have proceeded on with this reading, the patient based on SRKT, then of course this would have been 19.5 diopters with an expected refraction of a quarter of a diopters on the myopia side. But fortunately, this was not surgery. It was not did not proceed on with the surgery. 2 weeks later, this was repeated, and you find that the case has returned to almost its original position. So the SRKT now is 11.5 diopter. Post-op, the patient ends up spherical equivalent of 0, and he has a 6.6 unaided vision. Just imagine how much difference it would have made and how much problem it would have created. The next thing is, we all now Hyon Master 700 becoming more popular, or any strap source OCT. You can actually look at the image of the retina, and you can look at the fovea peak. Even though for Hyon Master is a 1 mm cut, it's good enough. Alright, if you have a fovea peak, it's a good fixation. If you don't have, it's either the patient not fixating or there's some macular pathology. Alright, so if you can see the fovea peak, obviously this is an optical axial length because you measure from the vertex to the fovea. Now in this case, no fovea peak, then you have to find out whether this patient has any problem. You may want to do a vitreoretinal OCT to exclude macular pathology. If not, then obviously this patient is not fixating. Alright, so this is just to show you the 2 eyes. One is 17.73 with an asymmetry. I mean, the system is trying to tell you something is not right about the excellent, while the other one is 26. It turned out that if you look at the image, there's the Hyon Master, sorry, let me change this to laser pointer. It's reading here. This is a retinal detachment. Okay, because the retina is detached, it's probably bullous, it can almost 1 mm shorter. The calculation would have been very different. You'll be surprised how often this happened, and it happened over and over again. So, so just have to be very careful. Do bilateral, almost always do bilateral, and you have a much better idea. Even if you don't do bilateral, 17.73 is very unusual. So that comes to data validation. Okay, if the axial length is less than 22 or more than 26, you have to be a bit more careful. If the standard deviation with the Hyon Master 700 is more than 20 micron, alright, ask yourself, is this a very dense cataract or the patient is moving quite a lot? If the axial length, like in this case, the axial length is more than 0.3 mm difference, it's a flag, just have to ask yourself, is this anything wrong? Finally, the axial length is not proportional to the refractive errors. I mean, short eyes for hyperope, long eyes for myope. You have to ask yourself what is happening, and you may want to repeat again. Okay, let me go on. Okay, this is just a show. Always do bilateral. Sometimes we just do one, the eye is going for surgery, but I always tell you that it's best to do bilateral because there's a kind of check as well, the difference in axial length between the two eyes with more than 0.2 mm. You know, and the difference in ACD more than 1 mm, or the difference in calculated metropic power is more than 1 diopter, or the difference in ACD between eyes is more than 0.2 mm. The first one is not correct. Okay, so you may want to calculate again. And not just calculate again, you can plan the surgery better, because sometimes what happens is the power here is half a diopter, 5 diopter, for example. You know, a lot of IOL, 5 diopter is where the minimum power is. If you don't do the other eyes, and when the next time you have to do the other eye, it turns out to be 3 diopters, then you are stuck. You have to use a slightly different IOL, and the counseling will become a bit more challenging. What formula to use now? I'm not going to go because of time how we calculate these matrices. For the line chart, the higher the better. For the bar graph, the lower the better. I've divided this into the newer formula. This is the traditional formula, and this is the modified traditional formula. Alright, from here you can see line chart higher better. The newer formula outperform the traditional formula, or traditional formula with modification. Alright, same with the bar, the columns, the lower the better. You can see that this is all much lower than this. These two lines are the average. This is the average for the line charts, and this the line graph, and this is the average for the column chart. You can see here quite obvious. There's no reason to use the traditional formula anymore. The new formula, the Evo, the Barrett, which is very popular, or the Hyo RBF, generally perform much better than the traditional formula. IOL constant. Alright, this is a new IOL. Of course, new IOL, there is always a problem. You're not sure of the final A constant yet. So we use A constant, okay? You can see that using a different A constant, the outcome is much more myopic the patient end up. So after we adjust it, you can see that the spherical equivalent starts to get much better. And this is not uncommon. Time and again, wrong constants being used, and with new formula, we are still stuck in the A constant. Then you really have to remember what is, for example, we use direct, what is the lens factor.
So they don't.
Okay, if you use many different IOL, well, then it's going to be much more confusing. Alright, so this is the myopia with the old constant, the initial constant, and with the new constant is much better. Take the proper history. One of the common things now is you never ask the patient the refractive history, and when you don't ask, you assume that the patient has not had LASIK, and then you use the wrong formula. Alright? Of course, there are some criteria, the CRW, to help you decide whether this patient has LASIK done or not. I will not go so much into it, or you can look at the difference between the TK and K. If the TK is much lower than K more than a quarter diopter, that usually indicates the patient has myopic LASIK. But for hyperopic LASIK, it's not so straightforward. Okay, always ask. Well, sometimes the patient don't even remember they have LASIK, the refractive surgery done. Then you really have to find a way to dig it out. They probably just tell you, I have some surgery done. Well, now LASIK is so common that some patients actually say they don't have any surgery done. Then you really have to dig it out. Have you worn glasses ever before? You know, that kind of question. For toric, you need to control the induced astigmatism. One of the things is wound-induced astigmatism, because the wound does make some changes to the cornea. So this is like trying to cross the river. The river, there's a current, you need to compensate for it. If not, you end up downstream. Alright, so this is a wound-induced astigmatism. But today, if you're doing 2.2 mm, generally the wound-induced astigmatism is less than 0.2 diopters. If you're doing, for example, 2.75, then you may want to use a quarter of the diopter. One of the paper discussed in ASCRS a few years ago, they find that there is an increased astigmatic error, post-op error, because the wound-induced astigmatism use was much higher than half the diopter. Alright, which is to say, try not to be too ambitious and think that your wound can correct part of the astigmatism. It should not be, the wound-induced astigmatism should not be more than half a diopter. If you are more than half the diopter, maybe you're actually introducing more error to the system. If you are not sure, just leave it blank, put 0. Of course, this you enter into the whatever formula there is. Finally, this is the Toric formula. You can see the Toric formula. This is Abulafia, what you call regression. It's not as accurate anymore. You should actually use either Evo Toric. I mean, these are the two major Toric or direct. Just going to, because this is very confusing, so I put it in another word. So Evo, TK, Evo. Whether TK does make a difference in your Toric outcome, well, usually it does not, unless the measure posterior corneal astigmatism is which has a steep meridian horizontally. Most of the time, the posterior corneal has steep meridian vertically, almost 90%, 85, 90%. But if it's horizontal, then you may want to use the TK, the measure TK. If it's not horizontal, of course, then you may just use K, that's good enough. Always remember the mark. If you use Callisto, so much the better, because the IOL master measure the steep meridian. Alright? Most of the time you are measuring steep meridians with reference to the horizontal axis, but the IOL master measure the steep meridian with reference to the conjunctival vessel. So no matter how you distort, how you cyclotop, your conjunctival vessel will also cyclotop, so your steep meridian, the relationship will always be more reliable than otherwise. Alright, of course you can use toric cam, which has, but toric cam is also with horizontal, not so much with the landmark of the eye. So, in summary, use optical biometry, because like I say, most of the error comes from ultrasound. Good fixation, because you want to have the optical axial length accurate, that means repeatable, do bilateral, choose the right formula, use the updated IOL constant, know your IOL constant, good refractive history. For toric care with wound-induced astigmatism, toric formula that take posterior corneal astigmatism into account, and of course you must always align your toric IOL, which is rotate. That's a problem. If you have a particular problem with a particular toric IOL that seems to rotate in your hand, you might want to change to one that's more stable in your hand. Thank you very much.
Thank you, Dr. Kuan. We open questions to the audience. Any questions for Dr. Kuan? If not, I'll ask Dr. Farman. Oh yeah, Georgia, yes.
I'll just shout. I recently tried to look at the literature regarding how long contact lenses should be out, and I found it really difficult to find that information. So I still don't know how long to tell my patients. I'm doing similar to you, a week for a soft contact lens, and we will tell them perhaps 2 weeks for hard, and then we will do the scans, and then I bring them back and I repeat the scans, and I'm looking for change. Does anyone have any comments on where this data comes from?
Okay, that's a very good and valid question. But I have thrown this question to the audience and to experts before. There are always different vested interests. Alright, from the business side, you want to do it as soon as possible. But ideally, if business is not your concern, you should repeat 2 measurements and get 2 consistent, until you get 2 consistent measurements. Which means, for refractive surgery, I will usually take 1 month to do 1 month consistent topography. I will go ahead. If they are not consistent, I will wait for until it become consistent. But you have to factor in dry eyes, because dry eyes may affect, but they are not big. They are just minor. So that becomes the question, because in the literature, even soft contact lens can take up to a month. There's some papers, because the optometrists have a lot of papers on this more than ophthalmologists have. So it's a very challenging question. But from my practice perspective, I find that I think probably 90% in a week they would have stabilized. Some take longer. The longer they have worn the contact lens, the longer you have to be off.
I have had some regular referrers who are experienced hard contact lens practitioners who sometimes help me by switching the patients from a hard lens to a soft lens a couple of months before they see me, and then the patient leaves the lens out for a week. But we don't always have that luxury, right?
No, and I'd rather they go to cold turkey faster, because you're just switching and then it just takes even longer, and then you introduce dry eyes in as well. So yes.
Well, that is an interesting question. So if you think about in the optometry world, right, do they stop contact lenses when they do their refraction? Not that I know. So
but they over refract. So it's a technique not to stop contact lens. You over refract, and if you need new contact lens, they just prescribe from there.
Okay. All right. So what about the role of topography? Do you think there's any role in preventing errors or repeating keratometry? Yeah. For toric calculations?
I think that's another very good question. That sometimes we like to bring it up, but the reality is I don't think so, because once you use a topography which is not an integrated keratometry, your constant will change. Alright, you must understand that this is a system, but whatever system you use, you can use, for example, lens start keratometry match with Hyon muscles or axial length, but over time you optimize your constant based on that what you call combination. But once you change any of the combination, your IOL constant will change. Okay, which means you have to re-optimize again. So I have never liked to use topography, because first, topography has a lot more noise than the keratometry. 2, then I have to re-optimize my constants. That means I have to do enough cases. To optimize a constant theoretically is you need at least 90 eyes. Alright, before you get constant. And actually, if you go into optimization, that's another whole talk altogether. So I generally avoid topography altogether. And then the next thing is, what K do you want to use? 2 mm zone, 3 mm zone, 4 mm zone. So if it's a straightforward cornea, as in most corneas, I think I would avoid topography. If it's a complicated, very complex, maybe we wait for Jascha and see what he's got to say.
So what you mean is you don't use topography values for calculations?
No.
You still use topography for screening?
For screening, yes.
Okay. Any other questions? If not, thank you, Dr. Fam. And next.
Thank you so much for the introduction, and thank you for having me. I'm very pleased to speak here, my first time in South Korea. And I'm having the pleasure to talk about pre-empting post-op surprise in atypical eyes, so the eyes that are a little more seldom than our normal eyes. My financial disclosures. So we already know that if we had or if we were used to the old formulas, they all had their weaknesses, and the weaknesses led to trend errors. So you always had to pick the right formula for the right eye, which could be quite complicated because it was not only XI length, but also K or ACD that could be a bit different, or a combination thereof. We have some of these current problems. Usually our biometers are validated via comparison to other devices, so we keep the same mistakes we already made in order to be able to have them FDA approved. So we still stick to a fudged XI length that is referenced to the ILM. We still have a fudged ACD, we have a fudged lens thickness, maybe even fudged posterior K values, but to be more precise, in all the atypical cases, we really need an XI length reference to the RPE, we need a real ACD, real lens thickness, and so on. So actually we would need better data to make that work, and that is why the current concepts struggle in atypical eyes and need some workarounds, and that is what I'm gonna talk about. Now, opposed to the classical formula, the new generation formulas already provide a better performance over a large group of eyes, and as we all know, we can now get them from the ECRS calculator. If you want to be a bit faster, I'm not saying that Hyon RBF should not be used, but if you want to circumvent any verification modes, you can just click out the Hyon RBF and you're going to be a bit faster. So some of the atypical eyes, let's talk about short eyes, because they're some of the more troublesome eyes. We have two studies here that looked at very high diopter lenses, so on the left side above 30 diopters, on the right side above 28.5 diopters. And you see a very similar picture. So if you look at the new generation formulas, you see that most of the new generation formulas perform perfectly fine. You see that Kane, per DGS, Evo performs very good. Also on the study on the right, we used an old Technis constant, but if we had used the new Technis constant, the Evo would have performed perfectly and would have been at the top, or among the top formulas in the study. So we see that all these new formulas that are provided in the ECS calculator, they all do quite a better job than the old formulas used to do. One exception, maybe the Barrett formula, at least before the sum of segments mode was inserted, that had some problem with the short eyes. Long eyes, there's a different story. With long eyes, the performance of the new generation formulas is no longer worse than a normal eyes. It got better than a normal eyes, which actually comes from the lower lens powers that you use. You have different mistakes that go into these eyes, and the lens position does not count that much into it. So your long eyes are no longer a problem, and with the new generation formulas, as I said, they actually give a better performance than short and normal eyes. Now let's get to the real atypical eyes that usually give you problems. One of those problematic cases can be keratoconus. As we all know, those are asymmetric eyes, sometimes hard to measure. And if we look at keratoconus eyes, we have to make a distinction between mild keratoconus, where both meridians are below 50 diopters, and advanced keratoconus cases. At least in this study, that, in my opinion, is a very nice job of showing how to use which formula. Puts the formula, or puts the keratoconus as advanced keratoconus if one of the meridians is above 50 diopters. Now, if we look at the mild keratoconus, and if we look at the new generation formulas, we see that all the new generation formulas, and I'm talking about the normal editions here, not about the specific keratoconus formulas, they perform quite good, so we don't have to change anything in those formulas. The only thing we might want to look at, and we may want to change, is if we look at the mean error. So we have a bit of a hyperopic surprise at around 0.4 to 0.5 diopters, and you may want to make a bit of an offset correction here and aim slightly more myopic in order to land it somewhere close to zero. That is the one distinction that I would make here for the mild keratoconus. For the advanced keratoconus cases, we see that the new generation formulas still perform better than most of the old formulas. The one exception is the SRK-T formula. We know the SRK-T formula usually performs quite good in eyes with weird corneas. So that's a one exception that doesn't even have an offset. So if you look Can I see my mouse here, my laser pointer? If you look here, the offset is quite low. And here again, the higher or the more advanced the keratoconus, the larger is my hyperopic offset. So I may want to aim a bit more into minus when using these formulas. But there are also the special keratoconus formulas. As I just said, in the mild cases, I don't think there's any need for that. The performance is quite similar to the new generation formulas, or maybe even a tad bit worse. But if we look at the advanced cases, we find that here the Barrett keratoconus formula with posterior cornea performs quite nice, and we see that the Carrot keratoconus also performs quite nice. So if one of the meridians is above 50 diopters, it makes sense to switch over and do the bit more of effort to get your calculation. What we also see is that Barrett, although it performs quite well, has a tad bit of an offset here with 0.5 diopters, so still you may want to aim a bit more minus, whereas the Kane formula is somewhere around minus 0.16, so you don't have to account for as much as an offset for the Kane formula, Kane keratoconus formula. If we look at the Zeiss device, the AMS 700, we have the TK values. Does it make sense to use the TK values? Yes, it does make sense in both cases, in mild keratoconus and in advanced keratoconus. As you can see here, with any formula, the TK version performs better than the K version, which goes for Evo, Kane, Barrett, Pearl DGS, K6, every formula, the TK mode performs better. Same goes here for the advanced keratoconus. SRK-T with TK values works better than SRK-T with K values. Same goes for Evo, K6, Kane, and all the others. So yes, please make use of TK values in keratoconus eyes. The next group of eyes are eyes with keratoplasty, with DMAC. Now we know we can have several modes for DMAC. We can do triple DMAC, we can do DMAC only, or we can do IOL first and DMAC later. What happens in these eyes? If you do IOL first, DMAC after, or triple DMAC, you have a problem that the cornea changes. Usually it is said that thickness and posterior cornea changes and that the anterior surface remains unchanged. I put a question mark behind it because I was not very convinced that this was the case, and we did a study on it and looked at it. And if you actually looked at the hyperopic shift, we all knew, so here you could see how the formulas performed in the cases, and you have a hyperopic shift of around 0.5 diopters, and if we looked at the difference of the K values pre to post-operative, you could see that the K values changed by 0.5 diopters, so the anterior K values are actually the enemy here, and that's what changes, which is a good thought for toric IOL patients. So if you have high astigmatism in those patients and you want to use a toric IOL, please do the DMAC first, wait a bit, and then do the toric IOL later on, because when K values change, obviously toric values and the axis may also shift. Now, if you look at what you can do and what you want to do, so if you go the classical way and do the triple DMAC or the IOL first and then the DMAC, you please do not use TK values. As I said, thickness changed, posterior K changed, and anterior K changed. So you have 3 mistaken values in there, as opposed to K, where you only have the anterior keratometry and then that changed. So K values perform a bit better in that case, but ideally you would account for the hyperopic shift, which you could do either by aiming at minus 0.75 diopters or just upping the IOL power by 1 diopter. Now, if you want to perform better, you you do the DMAC first and then use the post-operative values, and you can see that once you have the keratoplasty done already, the TK values perform better, and then it's the time to use your TK values in conjunction with the new formulas, Kane, Evo, or maybe even the older Hygis formula that give good values. Laser vision correction is also kind of a hard topic to get. We have a changed spherical aberration profile, so your oblate cornea in a hyperopic patients can be also oblate cornea after myopic correction, or your prolate cornea, which you usually see in myopic patients, can be a hyperopic correction. The anterior surface changed, but not only that, we have several factors that come in here, and I think that each of those entities gives you a bit of a different outcome and is a different source of refractive surprise. So obviously, if you have any scarring in haze, your total calculation will be thrown over because the anterior case changed so much. Not even the special formulas are very accurate in that case. If you have decentration and irregularities, can be the same. You have problems with high order aberrations, you have problems with irregularities. Epithelial masking can give you some troubles, but I think that's usually in the hyperopic formulas. And then you can have asphericity in a small optical zone that gives you also a different kind of error source. If you look at this picture here, you can see the pupil size and you can see the spherical aberration here, which is totally different than in this patient who will have less problems because the spherical aberration is quite good for the pupil size. This patient at night will have much less problems, and other areas can be chosen. I think I'm going to skip that due to timing reasons and skip over to the calculation again. Yes, so if we look at the formula performance of the current options that we have for post-laser vision correction eyes, thanks to TKU here, a bit of data with 900 eyes or 570 eyes with TK or PK values. So quite the large study here, and we can see that without TK or PK, the EVO LBC formula, Chemist-Cook formula, per DGS, they all perform quite good, and they all outperform whatever we have in the old AS0S calculator. And if we have TK or PK values, we even perform a bit better. So EVO PK does a quite good job, very true K TK. We have, oh, I thought we have that in there. We don't have that in there. Per DGS TK here it is, yeah. So we have quite a few options where we can make use of that, and all these options basically give you much better options than everything we had before. So you don't have to use the AS0S calculator any longer, but you can use one of these formulas here and get quite nice results. Not only in TK study, but also here another study from an American study group, which also looked at 576 eyes. And you could again see the same trend. So EVO 2.0 with PK values, very true KTK, per DGS PK, all with very nice performances. That even if you have only K values per DGS and EVO 2.0 and the EVO LBC version, quite up here. HIGIS TK can be used, but the elder versions like HIGIS L, which were based on elder ablation profiles, need to no longer be used. So if you have TK values, you can use them for keratoconus, post-DMAC, post-LVC, and normal eyes. Please don't use them for pre-DMAC and triple DMAC eyes. And that's it. Thank you for your attention. And questions.
Thank you very much, Jascha, for the comprehensive talk. Any questions from the audience?
I have a question. I have a question. Okay. How long do we have to wait for every K-values to be stabilized at this DMAC?
After?
DMAC.
DMAC, after DMAC.
After DMAC, until the stabilized. Quite the tricky answer. I don't think there's one threshold only, but I think waiting anything under 3 months makes no real sense. You see them changing quite often until 3 months. I have no. So it's just from experience answering now. I didn't really look at any study data when it really stabilizes, but my gut feeling would be 3 to 6 months until it's stabilized. Yeah.
Dr. Pham?
I'm not sure, but I'm assuming that you can actually do pachymetry until the pachymetry becomes stable after DMAC. Then that's probably the best time. Because initially they will all become thicker. Battery get thinner and thinner. Once it's stabilized, that's probably the best time. I don't know.
Maybe a good tip, yeah.
Well, I think the DMAC study is a really interesting study because we always thought the hyperopic errors is from the posterior lamellar transplant, but really it is from the corneal edema which changed the anterior curvature, and really Jascha really showed that and debunked something that was assumed and proven that actually is the steeper anterior cornea from the edema that caused a fake anterior K, which then resolved after the DMAC, which became flatter. So it was a really, really nice study.
And I think because you asked if some tomography device would be used, I think it changed also my way at looking at the tomography maps in Fuchs patients. So if you have a Fuchs patient and you see the tomography map and you see that the posterior elevation shows some floats, then in my head I'm thinking, yeah, that patient may have subclinical edema in the cornea, and then I may address that hyperopic shift to a certain degree, which is very opposed to a Fuchs patient where I don't see that posterior elevation in the that float in the posterior elevation map, where I don't do any hyperopic shift correction.
Any questions?
Just a comment around DMAC and triples, and it's difficult because it's such a varied group of patients with different degrees of endothelial disease. So I will have some patients who I'll offer DMAC triples who are overwhelmed at the thought of a cornea transplant, and in some countries there's very limited access to transplant surgery in any case. So I think broadly, if we are doing the cataract and we don't have the opportunity to do combined or do the transplant first, we should just be aiming for a bit of myopia in those eyes.
Yes, that's basically the Euler 1D or minus 0.75 offset, yeah.
All right, thank you very much.
Thank you.
These are my financial disclosure, and I will proceed my presentation in the order of the following agenda. To begin with our articulation, we must first consider the structure of the eye. Ocular power consists of corneal power and lens power. The eye will replace the press-down lens. Therefore, the eye power can be calculated by subtracting the corneal power from the ocular power. However, the eye is placed at the eye plane. Therefore, eye power can be calculated by subtracting the corneal power at the eye plane. It is called effective lens position from the total ocular power at the eye plane. Among the sources of error in the eye power calculation, the estimation of the effective lens position is the most significant contributor to this error. How is the effective lens position is estimated? In the thin lens pseudo-phakic eye model, the effective lens position is defined as the distance between the principal image plane of the cornea and the principal object plane of the IOL. However, many ophthalmologists are more familiar with the anatomical lens position. This is defined between the distance between the anterior corneal surface and the anterior surface of the IOL. The principal planes are two hypothetical planes in which all reflection can be considered to occur. These consist of the principal object plane and principal image plane. Let's take a look at the principal object plane and the distance from the haptic to the principal object plane. To determine the location of the principal plane of the image plane, first draw an incident ray parallel to the optical axis. Then extend the backward projection of the emerging ray that is reflected at the second surface of the lens and directed toward the immediate focal point. The points where these extended lines intersect define the principal image plane of the IOL. Similarly, the location of the principal object plane can be determined by tracing an incident ray that passes through the object focal point and an emerging ray that is reflected parallel to the optical axis. Now we can calculate the effective lens position as the distance from the principal image plane of the cornea to the principal object plane of the IOL. The principal object plane of the IOL can be calculated if the focal length, thickness, and front and back surface of the cornea, IOL and the reflective index of the IOL are known. In a previous study, which is conducted by Dr. Olsen and Ellis, it was shown that the prediction error was affected by the principal plane shift. The IOL in the study showed a sawtooth-like pattern of prediction error as the IOL power varied. When the effective lens position was adjusted according to the principal plane shift, the sawtooth-like pattern in prediction error disappeared and the accuracy of our power calculation was significantly improved. However, since the IOL is positioned in the back with the haptic supporting the equator of the lens capsule, in addition to the principal plane of the IOL, the volt height, the distance from the foremost haptic to the interior surface of the optic is also an important parameter in the estimation of the effective lens position. I conducted a study to investigate the impact of the distance of a principal object plane, red line, and the distance from the haptic to the interior surface from haptic to the principal object plane of the IOL purple line on the IOL power calculation. This research included both the optical simulation study and a retrospective cross-sectional study. First, let's take a look at the optical simulation study. In the optical simulation study, the distance of the principal object plane, red line, and the distance from the haptic to the principal object plane of the IOL purple line for Clarion Panoptics IOL, Elisa trifocal, Hyon, and lenses composite IOLs were calculated using geometric data obtained from the Korean government website. In the optical simulation study of the Clarion Panoptics, the volt height slightly decreased as the IOL power increased. The distance of the principal object plane shows a sawtooth-like pattern, and the distance from the haptic to the principal object plane also shows a sawtooth-like pattern with varying IOL power. This sawtooth-like pattern of the principal object plane is similar to the finding from a previous study. In fact, the IOL used in that study was a monofocal IOL from the same manufacturer. In contrast, Lisa trifocal IOL simulation, Lisa trifocal IOL showed a linear decrease in volt height as the IOL power increased, while distance of the principal object plane increased linearly. Consequently, the distance from the haptic to the principal object plane on the IOL showed minimal changes with varying IOL power. In the Hyon's IOL study, the volt height showed sawtooth-like pattern increasing with the IOL power and then decreasing. The distance of the principal object plane exhibited very minimal changes. Consequently, the distance from the haptic to the principal object plane increased up to 16 diopters, then showed a rapid decrease thereafter. In contrast, the lattice composite IOL showed a linear decrease in volt height as the IOL power increased. The distance of the principal object plane increased linearly. Consequently, the distance from the haptic to the principal object plane showed minimal changes with varying IOL power. In summary, the distance from the haptic to the principal object plane showed a sawtooth-like pattern in the Panoptics IOL, while the Hyon's IOL demonstrated a pattern of gradual increase followed by a sharp decrease. In contrast, the hypophilic IOL, at least a trifocal, and lentis composite IOL showed minimal changes in this distance across varying IOL power. We will now move on to the clinical study. The retrospective cross-sectional study was conducted at Korea University Ansan Hospital and the DGN Youngsub Hospital Eye Clinic, involving 160 eyes with Elisa trifocal IOL, 102 eyes with Technical Science IOL, and 51 eyes with lentis composite IOL. In the Elisa trifocal IOL, the mean age was 55 years, the mean corneal power was 43.83 diopters, and the mean actual length was 23.79 millimeters. As we can see in this graph, with IOL power on the x-axis and the prediction error on the y-axis, the Battle University 2, SRKT, Holiday 1, and Hayes formula exhibited those significant changes in prediction error relative to the IOL power. In the Hyon's group, the mean age was 65-year-olds. In the clinical study, the Hyon's group showed that all four formulas demonstrated significantly myopic shift as the IOL power increased from 16 diopters. In the lens comfort group, the mean age was 66 years old. In the lens comfort group, the better universal 2, Haggis, and SRKT formula exhibited no significant changes in prediction error relative to IOL power. In the optical simulation study, the distance from Haggis to the principal object plane of the IOL increased and it is decreased after 16 diopters. It is constant with the myopic error shift observed in the clinical study for the IOL. In the case of hydrophobic IOLs, the material is relatively rigid. Therefore, as the IOL power increases, manufacturers aim to avoid excessive thickening of the optics by adjusting the IOL anterior and posterior surface curvature at different rates. As a result, the red line, the distance from the Haggis to the principal object, changes significantly with increasing IOL power, which in turn can lead to variation in the accuracy of IOL power calculation. On the other hand, hydrophilic IOLs, which are made of relatively soft material, can tolerate increased optic thickness without concern. Therefore, the anterior and posterior curvature tend to change symmetrically as the IOL power increases. Consequently, the distance from the Haggis to the principal object plane remains nearly constant, and the accuracy of IOL power calculation is not significantly affected by the IOL power. In conclusion, this study indicates that the distance from the Haggis to the principal object plane plays a more significant role in post-operative refractive error than the distance of the principal object plane itself. The distance from the Haggis to principal object plane also predicted a myopic error trend observed in the IOL and a neutral prediction error trend, so the ELISA trifocal and then this composite IOL. Hydrophilic IOL, such as ELISA trifocal IOL, provide a stable IOL power calculation because they maintain a constant distance from the Haggis to the principal object plane regardless of the IOL power. Thank you.
Okay, thank you. So, it's open to the debate and comment. Any question, comment?
Okay, I'd like to highlight the importance of this paper, this presentation. We always talk about A constant optimization. A constant optimization only offsets your mean error, either up or down, hyperopic error, myopic error. But you can see the trend, especially for the Hyon, all the Technics lenses are like this. So once you reach 17 diopters or more, all the formats will end up with a myopic error. If you collect enough data, you see this trend. The only formula that compensates for it now is probably code K6, who has built in. All the other formula makers are moving toward, well, majority of formulas making towards this, because you can't just optimize, you can't even optimize with 3 constants, you can't optimize with the A constant. This is a non-linear trend, right? So all the formulas makers are going towards this, whereby different powers of different eye lens models would have different effects, and that's what's going to happen in the future. So what Youngsub is showing is that the Korean government actually collects a good amount of data from the companies so that we can see this, whereas the companies don't really show us in other countries. So, yeah.
Thank you.
Okay, you interpreted this result in terms of the IOL material. So, is there any chance that the IOL design affected this result?
IOL design itself can be affected on the effective lens position, so I considered the distance from Haggis to the principal object plane of the optic. If the IOL changes the Haggis offset or the angulation, it can affect the IOL power calculation. So whenever we use the first new IOL, we should consider the IOL design also.
Okay, if there is no question, you can move to the next presentation. Thank you.
Thank you.
He's going to present today about the management of refractive surprises in IOL surgery.
All right, thank you for attending this session. So, Okay, these are my financial disclosures. So despite what Dr. Fam and Jascha and everybody has been saying, how we understand IOLs, biometry, we can try and prevent errors, but sometimes errors still happens, right? So this is about refractive surprises. So the sources of errors, we know it can be from inaccurate biometry. Axial length is no longer a big error now with optical biometry. Usually now it's more keratometry, and to a lesser extent ACD and lens thickness. Atypical anatomy, short eyes, long eyes, the formulas have been improved to improve in short eyes and long eyes, but there's still more ways to improve for the short eyes. Hyperopic, myopic LASIK, radiokeratotomy, there are still ways to improve, and keratoconus as well. So sometimes we have a refractive surprise because we use inappropriate or inaccurate formulas, like for example you miss your LASIK history, or you still stick to the traditional formulas versus the modern formulas. Sometimes it's just a human error, right? We predicted 20 diopters, but for some reason you wrote in 21 diopters, you get an error. And the other source of error is, of course, from your refraction. Post-op, your refraction has to be accurate, can be poor refraction, especially in the atypical eyes, which are difficult to refract, and the premium lenses, which are difficult to refract, or the patient has poor ocular surface. So the management, I'm not going to talk about prevention because Dr. Fam has gone through that, but I'm talking about once the error has occurred, what can you do? Usually you have a choice of early intervention or later intervention. I usually reserve early intervention for really large refractive errors in the absence of cornea edema, right? You did a successful surgery, the cornea looks fine, but you end up with a +2 or -3 kind of error. So you know that it's a wrong IOL implanted, either from human error, from measurements error, for example, you miss the LASIK history. Then in these cases, generally I'll do our exchange within the first week or two post-op, all right, with the intended, actual real intended IOL. There's no reason to wait until 4 weeks. For me, right, because it's such a huge error. You want to make a patient wait 4 weeks for refractions to stabilize and calculate. I think that's not fair to the patient. Then you have the other errors which are not as big, right? Just maybe 1 diopter, 1.5 diopters, all right? But these are the ones that you reserve for later intervention. So you want to ensure that the refraction is accurate, and you really need to wait until about 4 weeks for the refraction to be accurate. To make sure the refraction is accurate, you need to treat the ocular surface. Usually like to repeat the refraction twice because all the calculation is based on your refraction. So to ensure that the refraction is accurate, you really need to repeat it twice to make sure that it is accurate. All the patients I would perform post-op case and axial length, right? Because otherwise you don't know where the source of the error is. Sometimes your axial length may be wrong, or the K may be wrong, so you'd be surprised sometimes you do a post-op K and axial length is completely different from what your pre-op values were. And of course, if you don't do topography or corneal aberrometry, you should do it. Because you may have missed out certain corneal pathology, especially if you missed out the history. All right, so the surgical options, there are three main surgical options. You have laser refractive surgery like LASIK. It is the most accurate, especially for small refractive errors. There's no reason to go and do an IOL exchange for like a 0.5 error or 0.75 error because the accuracy is not there. Right? You just should go for laser refractive surgery, especially for your enhancements after premium IOL implantations. Then you have piggyback IOL implantation. It is proven, it has been reported to be second most accurate after laser refractive surgery, and then the least accurate is IOL exchange. All right, so usually the piggyback IOL implantation you reserve for longer term kind of refractive errors. The patient had error for months or years. You think that the capsular bag is fibrosed. If you want to exchange, you may fear that the damaged capsular bag causes onlylysis. And then for eye exchange, usually you reserve it for patients, not in terms of refractive errors, where you have a big error early in the surgery because you missed something either from biometry or from history. Then eye exchange is of course easier in the early post-op period. Right, so for the formulas that do all this, called refractive vergence formulas. Most of them are refractive vergence formulas. So it relies on accurate refraction, less on biometry more on your refraction. So really, your refraction has to be accurate. So the current formulas that you can use are the Barrett RX formula, which covers both piggyback IOL exchange and toric IOL rotation. And then if you have the Holiday software, you have the Holiday R formula, which does piggyback IOL and IOL exchange. The Sharma's refractive equations are published in a book that's not available online. It's harder to use. And then you have your traditional rule of thumb method, which is for piggyback IOL. So basically, if you have a myopic error, you correct it in the 1:1 ratio. If you have a hyperopic error, you correct 1:1.5 ratio. So for example, one diopter of plus error, you implant a piggyback of 1.5. So that's the rule of thumb method. Alright, so for the Barrett RX formula, probably it is the most accessible and most complete. It's the easiest to use, right? You require your post-op refraction, which is the most important. Your A constant that for your IOL that was implanted, the A constant of intended IOL for either for piggyback or IOL exchange. You need your post-op case. Why? Because this is after surgery. If you use pre-op case, it doesn't reflect your actual refraction, right? So your post-op refraction should relate to your post-op case. So always use post-op case. But for the formula, you need the pre-op XLN, pre-op ACD. The lens thickness and white to white is actually optional. If you don't want to use it, there's no reason to enter. It doesn't really do that much, really. Okay, so on the Barrett RX formula, you have two options, the ALP option and the IOL option. So this is, it would be strange, what is this? So when should I use which? So for the Barrett RX, when you choose the ELP option, it is for most IOL errors, right? What it does is it adjusts the ELP based on your refraction to find an optimized constant and recalculate for the appropriate IOL. So it's adjusting what should be the ideal ELP. When you choose the IOL option, for example, you choose the wrong IOL power, then obviously it is, or you have an eye that has atypical cornea, where the error is mainly at the cornea or the IOL. Of course, it's not an ELP error. So for these type of errors, you have to choose the IOL option. So for example, if you have a +2 error because you put a low diopter lens, by mistake, right? Instead of a 20 diopter, you put in like a 16 diopter, completely by mistake. You can't use the ELP option because you will think that they should shift the ELP back to something else, but ELP is right, it's just that the IOL power you implanted was wrong. So that's the distinction between the ELP option and the IOL option. So that is the distinction. So you must know where the source of error is from. Alright, so for the Barrett RX formula, you can have the exchange option, which is on the left, and the piggyback option, which is on the right. Both works very well. Alright, so the other situation where you use piggyback IOLs is in atypical corneas, right? A lot of these cases, like post-LASIK, post-RK, post-keratoconus, you're not going to do laser refractive surgery if you have a large refractive error. Most of the time, the stromal depth may be not enough, or the RKs you don't think it will be stable enough, and the keratoconus usually have thin corneas, then piggyback IOLs is a good option. Right. So this is a study of 20 eyes with piggyback IOLs, 8 with previous laser refractive surgery, 6 with keratoconus, 2 with previous RK, and 4 with normal eyes. And we're looking at the Barrett RX Holiday R rule of thumb method and Sharma's refractive equations. Alright, so if you look at the results, you have the mean absolute error. You can see that the Barrett RX has the lowest mean absolute error. Holiday 1 rule of thumb. Surprisingly, rule of thumb is actually very good. It's not too bad. Mean absolute error about 0.408. The Sharma's equations, high error. But if you break it down, why is it that Barrett is more accurate? If you look at only the positive piggyback IOLs, right, you can see that they actually perform about the same. Apart from the Sharma's, the Barrett RX, Holiday R, rule of thumb performs about the same. The only difference is the piggyback IOLs that have negative power. The Barrett RX performs much better than Holiday R. Rule of thumb is not too bad. Sharma's much worse. And that's the reason, because the Barrett RX is a thick lens form. It counts for the geometry. So when you put minus lens, it accounts for the meniscus shape of the piggyback lens. It changes the principal planes. So that's why the Barrett RX actually works quite well for both positive and negative piggyback IOLs. And the rule of thumb, because there's a different ratio, it actually does pretty well as well. Alright, so next we're going to talk about errors in terms of toric lenses, residual astigmatism. For residual astigmatism, the source of the error is from keratometry, whether you make inaccurate measurements. If you only do one measurement, you rely on only one measurement, it could be inaccurate, or you have irregular astigmatism. Your SIA may be high, or you inputted the wrong SIA, eyeball rotational misalignment, you chose the wrong toric formula, and you don't use the posterior cornea predicting formula. It can be a refraction error, probably from a poor ocular surface. Alright, so for eyeball misalignment, the error can be from your reference axis marking, or your target axis marking, or in realign it wrongly intraoperatively. So the options to avoid is, of course, you either mark the target axis directly, you use electronic alignment system like a Callisto, there's no marking involved. During surgery, remove your OVD underneath the IOL and choose IOL with good rotational stability. Alright, so for your management, same thing for residual astigmatism, you need to find out the cause. A lot of surgeons assume that the error is always from IOL rotation. Do not assume it's from IOL rotation. Always do post-op keratometry, because we want to see whether astigmatism changed, right? We're going to compare with pre-op keratometry. This way you can calculate your SIA, whether there was a huge change in SIA because from your wound. Always do topography to see whether it's regular or irregular. Then you dilate your eyes, look at the alignment, right? And then assess cornea surface. Repeat your refraction, do it twice if you're going to do rotations or exchanges or piggyback eyeballs. Alright, so if the cause is post-op eyeball rotation, then of course you have to re-rotate the toric eyeball, alright? But the other options is, of course, again, laser refractive surgery, especially low amount residual astigmatism. Then you have your piggyback toric eyeballs, if you have fibrosed, scarred back, you don't want to exchange the lens. And finally, eyeball exchange if you implanted the wrong toric power, right? Because if you did wrong measurements, you have implanted a very high toric power or a very low toric power, which is wrong. And no matter how you rotate, it doesn't solve the problem. So really, then you have to do an eyeball exchange or laser refractive surgery. Alright, so when do you perform eye rotation? You have to confirm that the source of error is the eye position. Usually I'll do eye rotation if it's one diopter or more for the premium lenses, and you confirm on the online calculator whether it's the Barrett RX or any other rotation calculator that actually reduces your astigmatism, and the residual astigmatism have to be low. Alright, if it's not able to reduce it, that means it's not an eye rotation error. Alright, so when do you do eye rotation? So if you have a significant high astigmatism, right, and then for example, you know that your eyeball toric lens rotated 30 degrees and you have a residual astigmatism -2, you're not going to wait until, you're not going to wait until 4 weeks for refraction to stabilize and then rotate. It doesn't make sense. Practically, it does not make sense. So I would rotate within the first 2 weeks back to the intended axis. But if you have like -1, -1.25, you're not sure whether it's because early corneal edema or the wound has not stabilized, then yes, wait until 4 weeks. Make sure you get accurate refraction before you do any post-op refraction. Right, so the calculators that you can use again is the Barrett RX, and then also the astigmatism fix online calculator from Wendelstein and Hyon. The only difference between the two is this, that the Barrett considers the toric lens with variable ELP based on the Barrett formula. The Wendelstein and Hyon has a fixed ratio depending on the model of the eyeball. So the impact of this for toric lens is actually very low, so the difference is not that big. So that's why the outcomes are quite similar. Same type of patients, more parameters needed for the Barrett, less parameters needed for the astigmatism fix. So Barrett predicted rotating to 116 degrees, whereas the astigmatism fix predicted rotating to 117 degrees. So really about the same, not much difference. Alright, so when eyeball rotation calculations do not significantly reduce astigmatism, then the eyeball position is not the cause, and then so that means it's either because your refraction is inaccurate, you have to treat the ocular surface, or you've implanted a wrong toric eyeball due to inaccurate biometry or toric formula. Then these are all your other options. You can't rotate, there's no way to rotate and solve the problem. So in conclusion, for for our rotation, you can use the barrier RX or astigmatism fixed. For piggyback IOL, you can use barrier RX, Holloway R, low time. So preferably barrier RX because if you want to treat negative errors, and then our exchange barrier RX or Holloway R, both are quite fine. Thank you very much.
Are there any questions from the audience? Yes, please.
If we get a refractive surprise in premium IOL like refractive lenses, and we choose the laser vision correction to correct it, what do you think? What the best laser vision correcting?
If it's low, I think the most accurate is still LASIK, to be honest, especially for low amounts of refractive errors. LASIK is the most accurate, rather than PRK, because we don't know how much epithelium will remodel after PRK. So LASIK is the most accurate.
I think, if I may add something, I think it depends also on the error you have. If you have a plus error, then your plus profile is different than your minus profile. First thing is, sometimes with the plus profiles, you see that 2 years later they have the same error again, and it comes back from the epithelial remodeling. And the other thing is that you introduce spherical aberration and your visual acuity suffers a bit. So I'd make a case distinguishment between a minus and a plus.
So if you have a low error, I think laser is quite okay. Big errors, I'd like to change the lens.
Okay, thank you.
Yes, Dr. Chan.
How about ptosis?
Ptosis in terms of causing, well, I think he needs a plastic surgeon first before going for biometry and all that. So yeah.
you correct it first?
Okay, so to be honest, we've all been taught to do cataract surgery before oculoplastic surgery, but if you feel that the ptosis really is causing inducing astigmatism, it doesn't make sense, right? So really, of course, do the oculoplastic surgery before any cataract surgery.
But actually, the oculoplastic will.
Yeah, exactly. But then you tell them it's causing astigmatism, then they will be responsible if you do the cataract first. Yeah.
Let's say you have a patient after laser vision correction, maybe an old profile with high spherical aberration, monolith profile, and you're at minus 1.5, or maybe a keratoconus at minus 1.5. Do you do laser vision correction, or do you do piggyback?
Minus 1.5. Generally, I'm a cataract surgeon. I still do piggyback. Sorry, but will you do laser? Keratoconus? No.
Probably I would try to use the laser and get the wavefront profile a bit better. And
with cross-linking or?
Huh?
With cross-linking or not?
Depends on the age of the patient. I think with minus 1.5, depending on the case of the cone, I'd probably, maybe I can go without sometimes. I think with the laser vision correction profile, if I can enlarge the optical zone, I think it may be worth trying the laser vision correction
to
instead.
reduce the spherical aberration.
Yeah.
I did an IOL exchange recently. I removed a trifocal diffractive lens because the patient wasn't happy with his range of vision and quality of vision. And we were looking at the IOL exchange formulas, and we weren't sure what AC depth to use, and we couldn't get a pseudophakic AC depth off the IOL master, and we just weren't sure what to use in that scenario.
It is all pre-op AC depth. Sorry, you do not need post-op AC depth. It does not do anything on the barrier RX. If you put the post-op AC depth, it may lead to some error. It's all pre-op AC. All refractive divergence formulas actually main key values is refraction, case, and axial length. The rest are minor, but don't use the post-op AC depth.
Quite confusing when you're putting the data on, because some areas were very clear saying insert pre-op and some said post-op, but I missed it.
I think I learned it from you. Wasn't it you told me? I think what I do in some cases is I just calculate a fake gig or a piggyback IOL, and that's the amount I changed the lens by. I think you told me that.
I can't remember.
Yeah. But it was a very nice idea, and I stuck to it.
So if you put refractive surprise in the first eye, would you adjust the target in the second eye, or you just go check?
Really, I think it depends on the source of error. If you know that your biometry, refraction, it's not an atypical lens like what Youngsub was saying, then yeah, you want to adjust for the fellow eye. With a certain, not exactly the same amount. I think a safe amount is about probably 30% adjustment, because if you commit too much, you may end up with overcorrection. So I think 30% adjustment is quite safe, depending on the form. What do you think, Andrew?
I think I just checked the validity of the biometry. So if everything is okay with second eye, I just stick to the original target. But if you get the eyes atypical, then it's the second eye.
Yeah, I'm never sure a week after. I'm never sure what to do with my refraction, to be honest. So if I have like a month in between, then obviously I think 50% visually, 50% of the refractive surprise. There's enough studies to say it's good.
Yeah.
But with the 1 week refractions, I'm never sure if I should use the.
I have a question. First for Fam. You mentioned the refractive eye drops can affect the readings. So in your practice, what do you do?
I would ask them to bring a few more times.
No, but do you dilate them before you?
No.
You don't. So every case that comes in, you do a biometry.
Yes.
Oh, okay. Second question is, how about angle alpha and angle kappa?
In terms of error?
Yes.
I don't think there's a, well, if the patient is fixating, then it should not be an axial length or keratometry error on biometry. So I don't think it's an issue. Yeah.
I think angle alpha and angle kappa is more for multifocal. For monofocal, I don't think you can get.
Yeah, for multifocal. So
Well, if you're talking about prediction error, I don't think there's a difference in prediction error. But if you're talking about patient dysphotopsias, I think there's two different schools. I belong to schools whereby angle alpha is not an issue. But, yeah, because I haven't seen a big angle alpha causing a big problem. Yeah.
what's the maximum you allow when you put it?
Yeah, so I don't really look at it, to be honest. Yeah, so I mean, there's always a cutoff that's guided by certain papers, but if you look at the papers, some of the papers don't even find the difference between large and capital and not.
I think most of these are in high hyperopia. I mean, most of our populations, for example, mainly myopia is not a big problem.
Thanks very much, and it's a thrill to be invited to be part of the faculty here. So I'm going to specifically look at Callisto. Who here uses Callisto for their toric IOL alignment? A couple of people, so hopefully the rest of you will get the opportunity and these tips will be useful for you. Can I use this?
It's really big on it.
Great. And here are my financial disclosures. Yeah, all good. So in Australia, we use a lot of toric IOLs. Across all of Australia, 36% of all IOLs implanted are toric. And looking at my own data for this year, in my private practice, have used 74% toric lenses, and in public, 22% toric. And right now, my most common intraocular lens type is toric EDOF. And that's different to last year, just with different models coming out and trying new things. Now we know that using a toric lens does take a little bit longer, and so I'm using 74% of these in my private workflow, so I want to maximise efficiency. And I'm fortunate, I work in 4 different private hospitals, and I don't do any manual marking. I don't have to look at a Mendes ring anymore, thankfully. And since 2021, I've had access to the Lumira 700 microscope with Callisto Eye. And then at the end of last year, I've also had access to the updated microscope, the Artivo 750, also with an updated version of Callisto Eye. So that has been great. But if you have the opportunity to use Callisto, you need to really understand how it works. And it's pretty simple, but sometimes when it gets set up in the operating theatre, you may find that your techs or your nursing staff, or even sometimes the surgeons, don't really quite understand how it works, and they might rush through the steps, which could cause errors with IOL alignment. And ultimately, we want to put that lens along the correct axis. So it's pretty simple how it works. It's matching our scleral image, so we're going to obtain this on the IOL Master 700,
So we have a scleral image with blood vessels, and we're matching that to the live intraoperative image. So if we look here from the same patient, we can make out some of those blood vessels. Hopefully, no, we can't see my pointer there, that's okay. This one, is it? Yeah, so some of the prominent vessels we can make out here and here. So we're going to match that in the live intraoperative image, and then we will overlay the 0 to 180 axis and our intended toric axis. And so once we're in the operating theatre, we're going to have the patient nice and still. Well, there are 4 markers on the Callisto, and it will not proceed unless we've got good alignment, good centration, good lighting, good magnification. And then once it captures an image, we actually need to stop and we need to look at the images. So we see the scleral images in the top row here, so they're in black and white, and we want to match these images with some intraoperative images, and you can have this grid pattern here, and you want to look and see that the blood vessels are actually matching. And I have worked in theatres where the techs have just okayed without looking, so you need to stop and check. Now, so tip 1, understand how it works. It's pretty simple. Now, if you've got an eye that has an enormous subconjunctival hemorrhage or chemosis from a block, then it may not work at all. And that's not Callisto's fault. It's because there is no match that's going to occur there. So I tend to do most of my cases with topical, but if, for example, you use blocks, or perhaps you were doing a high-powered multifocal case and the patient needed a block, that might be a case where you'd consider manual marking because you really need to get it right. So, and we really need good quality scleral images, and this may be something that comes up tomorrow with your talk mastering, the IROL master. Your staff should be trained to get good scleral images, and I found in one of the practices I worked in, our techs were kind of skipping through this. This scleral image is essential for me to use Callisto in the operating theatre. And we want to see as much of the medial and temporal limbus as possible. So this picture is not terribly great. And in some cases, our team are lifting the eyelid up. But the case earlier with ptosis, it might be hard in those cases. And we want it nicely in focus. And once I'm in the operating theatre, I have got autonomous control of the Callisto system. So I've got the buttons set up on my foot pedal and on the hand pieces. So once we start the case, I can tell Callisto what to do, I can accept the images, I can move forward to the next steps of the surgery. So I'm not waiting for any technicians to press the buttons on the microscope. And then another thing to make sure you've done is that you actually have your Callisto data set up in the microscope. So I work in a couple of places where we've got a wired system that we can pull our data in, and then I work in other centres where I've got to bring along the USB stick. But don't start your surgery until you've checked that the scleral image is there. I have been caught out with that once before. I have a patient, they're sedated, they're on the table in front of me, so always check. I've been caught out. And another important thing is that you want to do your team timeout. I don't have access to EQ Workplace where I would see the IOL power on the microscope, but with the updated Artivo 750 system, part of our timeout will actually stop and we'll check the lens and we'll look at the operating microscope and we'll confirm the eye and the toric axis on the picture here. So that's a really important part of patient safety. Okay, so we want a good pre-op scleral image, and now, once we're in the theatre, to get our image registration, we've got to give Callisto a nice intraoperative image. So actually, everything's going to work best when the patient's really well positioned with no head tilt, where everything's nice and level. That's going to make your surgery easier anyway. So position your patient really carefully. I'm always annoying my anaesthetist, saying, no, I want a bit more chin up, chin down, move the head. And if they think I'm being difficult, I just say, oh, look, it's because the Callisto won't work, so you can blame it on the microscope. And then, when you're about to do your image registration, make sure the limbal blood vessels are in focus. It will actually do the image registration step if it's completely out of focus. And then when you look at your pictures, you won't actually be able to make a good match. And I thought I had a picture there. I will see if that one comes along. Okay, another thing, and I would love to hear how this applies to you, particularly with smaller Asian eyes, but choosing the right speculum. So in Caucasian eyes, most places I work have these open loop Lieberman speculum, and they're quite long, some of them, 15 or 16 millimetres. So in a really small eye, you try and get that in, and you end up with a rectangular palpable aperture, and you can't see the superior or the inferior limbus at all. So I found when we were transitioning to Callisto that we actually had to order in more paediatric speculae, which was smaller, and you've got more of a diamond shape opening there. And this was a patient who she had quite tight lids, and I was actually unsure if I was going to be able to get good access. In the end, I could get it open well, but Callisto really needs to see all of the limbus to do the registration image there. Another patient group that can be a little bit tricky are patients with really dense arcus, because the edge of their cornea is white, so Callisto can't pick up the location of the limbus, so they can be tricky as well, and might be a group where you might consider doing pre-op marking. And again, this is just the paediatric Lieberman speculum, so it's much smaller. I think the length here is around 12 millimetres. There may even be smaller ones, but this is a case where I just couldn't proceed with the normal speculum. And again, correct head position, addressing any head tilt. So this patient, their chin was down a bit, so I did an adjustment, and sometimes if I still can't quite see all of the limbus, I'll just lift up the lid and pull on the speculum a little bit just to get the access, and then the Callisto will let me go ahead. Now here's this picture with the blood vessels. So Callisto will let us do the image registration even if it's out of focus. So if you just look down the bottom there where the blue arrow is, you can't really see the blood vessels right at the tip of the arrow there. But if you do another image acquisition, you can see that they're much sharper. So if you just spend that time getting it sharp, it'll make things more efficient as you go along. And in some eyes, they don't have much in the way of blood vessels, but you can always have a sneaky look at the iris markings. So this is a nice example where there are some iris nevi, and you can match those when you look in the images along the grid there. And then finally, keep the conjunctiva nice. Now this is a patient who, for some reason, we didn't have a scleral image, so my anaesthetist did the marking pre-op. You can see they're pretty big marks. But you can see that Callisto's getting confused here. The yellow horizontal mark keeps moving. It's getting confused, and there's some heme, there's some blood down here from my main wound, so it's interpreting that blood as the manual mark that's been put there. So in this scenario, you just have to keep clearing that blood away, and then it will come back on track there. So keep the conjunctiva nice, trying to avoid hemorrhage, chemosis, and topical is very well suited. So for me, I find it faster, and I'm fortunate that I no longer have to do any manual marking. I think it's more comfortable for the patient. I'm not going through hundreds of marker pens, and I don't need any extra surgical instruments. So for me, it's been an effective tool, and it's helping me maximise my time in the operating theatre. Thank you.
Last question.
Thank you for the warm introduction. Good afternoon, everyone. Thank you for being here, especially on Saturday afternoon. My name is KyungMin from Kimsa Hector, Kuan University, South Korea. Today, I'd like to share some clinical case of cataract refractive surprise. Before I begin, I'd like to take the chance to warmly welcome the other presenters in this session. It is an honor to see the distinguished Dr. Bor Fam again, this time in Seoul, after our meeting in Santa Barbara. And it was also a big pleasure to see the respected Dr. DK again, and great to have Dr. Jascha back in Seoul after such a long flight. Okay. Welcome to Korea. As Dr. Martinez, the developer of the Pearl disease formula, once said the difference between an iron formula and a dog is that a dog doesn't betray you. And that line stays with me because it feels so true. Refractive surprise after cataract surgery is something every cataract surgeon inevitably faces at some point. I'm going to present the 6 cases of the cataract refractive surprise, and I have never encountered a cataract refractive surprise with Zeiss eyewear, so unintentionally, all my 6 cases is involving eyewear from manufacturers other than Zeiss. The first patient I would like to present is a 53-year-old female. She had a BBT eyewear implanted in the left eye in 2022. Target refraction was minus 0.2 minus 0.24 diopter, but the actual spherical equivalent was minus 1 diopter. She had already undergone cataract surgery in the right eye with a monofocal IOL targeting far vision. Her pre-op uncorrected visual acuity was 1.0 in the right eye and 0.4 in the left eye. Please note that all the visual acuity values in my case are shown in the decimal format, as it's standard practice in Korea. After surgery, she complained of poor far vision in the left eye, even though her intermediate and near vision was so good, and she refused the IOL exchange or PRK. She had a steep cornea with a K value reaching almost 46. All formulas failed to provide an accurate prediction of the post-op reflection. The second patient is a 77-year-old female. She got symphony in the left eye. Before surgery, she had minus 2.5 diopter of myopia, which is within the range of golden myopia. I targeted minus 0.69 diopter to preserve her near vision, but the actual post-op reflection was staying between minus 2 and minus 3 diopters, like the pre-op value. Likewise, the patient also had steep cornea with a mean K value of 45.2 on topograph and 45.5 on the IR master. Third patient is a 52-year-old male. In 2002, he got the symphony IOL in the right eye. Considering the patient's age and pre-op myopic status, I planned for a target reflection of around minus 1 diopter. However, the actual reflection was minus 2.5 diopter, which was a true reflective surprise. Thanks to the EDOF design of the simple IOL, his uncorrected visual acuity was at least 0.2. He also had a very steep cornea with a K value of 49. This K value appears unusual steep for an actual length of 24 millimeter. Of all the cases I am presenting today, this case appears to have the greatest risk of K measurement error. Moreover, this patient also had a severe dry eye with extensive meibomian gland dropout on meibography. Anyway, due to the large refractive error, I rechecked the case using the ESS calculator while preparing this presentation. As shown below, the most formulas still predict reflection of around minus 1 diopter. The fourth patient is a 27-year-old female who underwent the bilateral symphony IOL implantation. Considering the patient's young age and pre-op myopic status, the target reflection was minus 0.76 diopter in the right eye and minus 0.89 diopter in the left eye. As a result, there was a myopic shift of more than 0.5 diopter from the target reflection in both eyes. She also had a steep cornea with a K value greater than 47 in both eyes. The fifth case was the 67-year-old male with bilateral IOL. The target reflection was minus 0.3 diopter in both eyes. However, the actual post-op reflection was minus 1 diopter in both eyes, resulting on myopic shift greater than 0.7 diopter in both eyes. He also had a steep cornea with K value greater than 46 on both eyes. The last patient is a 44-year-old male with a history of PRK who received the pure IOLs in both eyes earlier in this year. He had a long eye with an axial length over 28 millimeter, and there was a myopic shift of 1.5 diopter in the right eye and about 1 diopter in the left eye compared to the target reflection. The K value were low, around 34 in the right eye and 35 in the left eye. The bilateral K and Hayes L formula showed inconsistent refractive prediction. Here are some important factors that affect refractive outcomes: accurate measurement of axial length, corneal curvature, and chamber depth, and lens thickness, and accurate prediction of ELP and appropriate IR formula and IR constant. With the advance of the anterior segment OCT, the accuracy of axial length and chamber depth and the lens thickness measurement have become nearly perfect. Unfortunately, however, K values still present large fluctuation. Since I didn't analyze the ELP separately, the most likely cause of the reflective surprise in my 6 case seems to be the inaccurate measurement of the cornea K value. As we know, with age, both cataract and dry eye syndrome become more common, and tear film instability reduces the reliability of the K measurement. And the K value is the most important factor in IOL power calculation. An error of 1 diopter of K value will result in an IOL error about 1 diopter. We all know that in eyes with this condition, K values and topography are not accurately measured due to the cornea erosion and tear film instability. Many experts are emphasizing the importance of careful K measurement and recommending the principle of measure twice then cut once. Based on this, my conclusion is that in patients with tear film instability, it is very, very important to treat ocular surface before performing biometry, and in addition, repeating biometry at least twice before surgery can help reduce the risk of cataract refractive surprise. Thank you very much for your interest.
Good afternoon, everyone. Thank you for the opportunity, and guys also for letting me standing here. So you have a refractive surprise, and now what? So this is my financial disclosure. Something unexpected happens. Yeah, I just was bored. For refractive surprise, doing nothing is always an option. Not every refractive surprise require further surgery, and low myopia may give you some more vision and the ability to read unaided, willingness to wear glasses for those patients, and the benefit of risk of further intervention should be excluded too. Surgical treatment, like Prof. Kuan already mentioned, that the option was LPC, IOL exchange, piggyback IOL. The treatment considerations also refractive errors, myopic, hyperopic astigmatism in combinations. Parent time of the first surgery, the type of surgery, lens, cornea procedure, type of IOL used, IOL design and material, the instrument availability, because not many of us have the complete instrument, and the range of IOL power availability for replacement or replacement of IOL or piggyback. Cornea refractive surgery is always the easiest and the easiest way, because good option for refractive surprise, large range of refractive error. Of course, it's also we have to consider the condition of the cornea. And after refractive achieved, typically after 3 months, careful with resistance of ocular surface disease should always be checked. Yeah. But this case is not always available in our country, so refractive center is not many of us have laser vision corrections. IOL exchange ideally performed soon after the initial surgery before the capsular fibrosis has occurred. Usually the black IOL adhesion occurred in 14 20 first day until 3 months. Yeah. Large refractive correction rates depend on IOL power availability, because in my country the IOL power availability between -10 to +20. And best to know the previous IOL power to compare with the recent biometry. Sometimes the problem is we don't know the IOL power, and we don't know the effective lens position of this lens. Yeah. So be very careful if we plan to do the IOL exchange. The IOL exchange with high risk of damage the capsule, risk of vitreous loss, and longer the initial surgery, the higher the risk of capsular fibrosis. It is ideally the whole lens can be explanted, or at least we can remove the optic part and leaving the haptic if it cannot be freed. But also it is important to identify the type of IOL, the material, the design, and the location of the IOL implanted, whether in the back, in sulcus, or sulco back. You skip this one. Yeah, this is IOL exchange after 3 months. Yeah. For our centers that they are using the hydrophilic IOLs, then we can clean up the fibrotic and then do a physical resection. This is a monofocal IOL. Even after 3 months, we can still do a explant the IOL and free from the back and explant the whole lens attached. Use a cohesive viscoelastic to do a physical resection and make sure you can rotate the lens before you force it out of the bag. Be very careful with your power, because sometimes we cannot measure the power. You see how easy the lens can be explanted. And after it's in the antechamber, then your choice whether you want to cut it or you can take it whole. For my choice, I rather to just remove the lens with the complete rather than cut it, because I'm afraid it may injure the back or in the cornea. Put the haptic on the side of the wound so you can have a good grip on the haptic. And I'm using a second instrument as equalizer to make sure that the optic doesn't touch with the inner wound of the lens. Pediatric IOL is fast and simple surgery technique. The power of the primary IOL does not to be known, but can be performed on every case regardless of time of initial surgery. But refractive correction range depends on eye power availability, as I mentioned earlier. Less accurate compared to laser refractive surgery, but still a good alternative to avoid the risk of IOL exchange, as well as those with ocular surface disease when LPC is not suitable. The IOL power calculation, my preference is the rule of thumb, like Prof. already mentioned. For myop is times 1.2, for hypermetropy is times 1.5 to determine the pediatric IOL power. This is my case actually. This is only to show you how easy pediatric IOL. My case was a female with high myop and a cylinder. She refused to do multifocal in the first place, but after I used Atypical for this case with a good refraction post-op. But after 3 months, she wants to have a multifocality in the case. And then I put other brand that Sulcus, they have a trifocal. You just need to make a wound and then use a cohesive viscoelastic. And then you just inject the lens in the sulcus. I always use the bimanual technique with the second instrument. Just make sure that you open the sulcus and make good room for the lens itself. So you can always put the lens in the sulcus, and since the it's already pseudophilic, so we have quite big room for another lens. Just make sure the edge of the center of the first IOL is matched with the second IOL. Be very careful sometimes because the first IOL can be addition to the second one. So if you find it difficult to rotate, my preference is just to manage with the haptic, and then make it the center of both lines match. Simply by looking at the edge of the both IOL optic, and then we remove the viscoelastic. My case was this is the last time that I used a scan biometry for my multifocal IOL. It was 65 years old lady with the -2. With the cataract with 1 and 2 and the multifocal power was 21. One day of the refraction is the refractive surplus is already -2.5 with cylinder 0.5. She was happy with the clear vision, but dissatisfied with the far vision. And after 1 month, her vision acuity become -3 with 0 cylinder. And after 2 months, the surgery, patient agreed to undergo an IOL implant, and I intended to put the lens in sulcus because the lens was multifocal, and it's expensive to explant the lens and change it to another multifocal. And then with the rule of thumb, I made the calculation, so I put the -5 this lens, and as a piggy bank, it was this simple, and the refraction post-op was one month was 0.9 and cylinder 0.5, and the visual acuity was 100%, 6/6, G1 for visions, and patient was very happy. My analysis with the male, 30 years old, with historic cataract surgery earlier, before, 14 years ago. No history of laser and secondary cataracts, and the degree of refraction is hand movement, spherical correction with -10, and cylinder 1.5. Respective power is -4 with the visual acuity even 1 meter finger counting. But the corneal documentary was 508, so LVC was not an option for this case. So I dilate the pupil so to identify the lens wasn't KyungMin lens. The surgery was the manual cataract surgery. As you see here, the arsenic here anterior the 10 o'clock, and the haptic is on the 5 o'clock, and you see the lens was put in sulcus. So I intend to do an IOL exchange with this case. And you see they are already the capsule intact with the fibrosis in the periphery. Both eyes about the same. The way of thinking was because the refractive correction is -10 with corneal documentary 508, LVC is not possible. Piggyback IOL implant is not preferable because the primary lens is already in the sulcus. The IOL exchange will be performed from temporal approach for easy access to the haptic IOL. My surgery preparation is IOL system may not be so possible because PMMA was be too hard, so I intend to take the lens whole, without cutting the lens first. I prepared anti-vitectomy, if possible, capsular rupture during surgery, and nylon sutures for the wound if it's large. Any break? Yes. This is about the same for the first and second eye. Make a temporal incisions. Don't be afraid to make the incision as near as the haptic, so you can get easy access to the haptic. The lens will be easily explanted from the sulcus, but sometimes it's already fibrotic, so I don't force the lens to get it out. And I decided to cut the haptic first, and at least I can free the optic. And to secure the posterior back, I lift the lens away from the back and then cut the optic and then take it out. This is I implant the second lens first as a glider to protect the posterior capsule. I use a 3-piece IOL and then take the first lens out and put 2 or 3 nylon sutures. This is the one month follow-up, the visual acuity is 0.6 with -1, and the visual acuity is 0.9 for the right eye, and 1.0 for the right eye, and addition with 2.75. The patient still complain that why should I have a multifocal IOL? So the multifocal IOL is no longer suitable for this case. This is my third case. This is a patient with toric multifocal. What I want to mention here is like Prof. Tun said, that it's not that easy to rotate the toric IOL after 1 month. Sorry. The case was toric multiple IOL. 1 day post-op was 1.0 and 1 week was 0.8 with the cylinder 0.75. Okay, and I tried to rotate the lens after 1 month. And unlike the first case, when I can explain the IOL, for this case, it's very difficult to open the sulcus. To open the back, sorry, I use a cohesive viscoelastic. I tend to free all the attachment of the anterior capsule and posterior. It was very difficult. Even though maybe I can free the lens, but I cannot re-rotate this lens to the intended axis. So I'm afraid if I take the lens out, I'm afraid I cannot take it back into the back. And so I close the wound and tell the patient that the re-rotation is not possible. So in this case, I will do a laser vision correction, even though it's only 1 month. It is very difficult to take it out, and I don't try to force it because it may damage the back. At least I know that the lens is stable in the back, and I can make sure that the refraction is already stable. This is the Atypical B. Atypical Toric, sorry. Yeah, maybe patient have a eye rub in the first day, in the second day, or between 1 week before the surgery. So he cannot remember also. After a few minutes, and I decided this is impossible to rotate the lens. And I just bring the viscoelastic. As you see, I can easily lens the lens off the back, but I didn't do it because I'm afraid I cannot put the lens back to the back. So in this case, I will do a laser vision correction, but of course, I will do the surgery on the second eye with the also toric multifocal, and I tell the patient that if you have difficulty in adapting with the both eye with the difference of 0.1 diopter, and then we may perform a laser vision correction. But if he comfortable with it, then just let it be. Intraoperative not expected. IOL will perform in less than 1 month post-op for many reasons. It will be easily visco dissected. I will be easily rotated and intended ciliary axis, but in reality, it's already fibrotic, and visco dissection is so hard to do, and forced dissection may cause capsular rupture. IOL is well sealed in between the anterior and posterior lines, and IOL can be free from the back, but the intended ciliary axis was not impossible to open. Once the IOL can be free from the back, it may be difficult to put it back in the back. So axis rotation will continue to prevent further trauma to the back, and laser correction will be the last choice. I think this is the same. Thank you, everybody.
Thank you for the illustration of your cases. I think we're a bit far in time. Are there any short questions?
Just
one question allowed. No questions?
Can I ask? I think I just want to ask Dr. Ko. Do you think it's always just dry eyes or just a steep case? If you don't, did you repeat the case? Were they different after treatment? Yeah.
I didn't repeat any biometry or biometry. In that time, I actually have no idea about the the importance of the K measurement. So next time I have the case, I will do that.
It would be interesting if the pre-op and post-op case were big, significantly different. And a lot of them were Tech-based lenses, so maybe because of what Youngsub. I think that's
Perfect. So thank you everybody for showing up. Thank you for your attention, and enjoy the rest of the conference.
Thank you.